Good morning, everyone. My name is Martin Blazer. I'm from Rutgers University, and I serve as the chair of PACCARB, Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. I serve with Dr. Michael Apley from Kansas State University. Today is day 2 of our 22nd public meeting. On day 1, we had a very lively and informative session about communication. Day 2 will focus on equity. Our efforts are led by Drs. Joni Sheftel and Ramanan Lakshmanarian, and you will be hearing from them shortly. Dr. Apley, do you want to say a couple of words of welcome?
Thank you, Dr. Blazer. Welcome, everybody, our panelists, those attending from the public, and our council. And with that, I'll go ahead and turn it over to Dr. Musmar, our designated federal officer.
Thank you, Dr. Apley. Welcome, everyone, to the second day, as mentioned by Dr. Blazer. Yesterday was full of in-depth discussion on ways to strengthen scientific communication as we prepare for the next pandemic, which is currently our task for the Secretary. Today, we will hear from a variety of experts as we explore the unique experiences of vulnerable and marginalized populations and address equity concerns throughout our pandemic scenario. But before we begin, a reminder to everyone that this meeting is being recorded. Also, we have our live verbal innovation spotlight, so if you'd like to join us, there are still spots available for this afternoon. Third, and the formalities, the Advisory Council is governed by the Federal Advisory Committee Act, or FACA, and as such has rules about the circumstances by which agencies or officers of the federal government can establish or control committees or groups to obtain advice or recommendations where one or more members of the group are not federal members. The majority of the work of this advisory council, including information gathering, drafting of reports, and the development of recommendations, is performed by designated working groups, such as the Pandemic Preparedness Working Group that's chaired by Drs. Joni Sheftel and Ramanan Lakshmanarian, who in turn report to the full council for deliberation and final vote, which for our purposes currently will be at our upcoming March 23rd, 24th public meeting in person at the Hubert H. Humphrey Building in Washington, D.C. Regarding the conflict of interest rules, all 15 voting members of the council are considered special government employees and are subject to conflict of interest laws and regulations, as are the 12 regular government employees representing different agencies and departments on the council who have also been vetted for any conflicts of interest. Everyone's received the information regarding the standards of ethical conduct for employees of the executive branch. And now we'll go through a roll call for all council members. Please let us know if you are present by stating here. For alternate representative members, please identify yourself and provide the name of the principal you are representing today. So we'll start with our voting members. Dr. Blazer.
Here.
Dr. Apley.
Here.
Dr. Stephanie Black.
Here.
Dr. Helen Boucher.
Here.
Dr. Virginia Fate.
Here.
Dr. Paula Fedorka-Cray.
Here.
Dr. Christine Ginocchio.
Here.
Dr. Locke Carricker.
Here.
Dr. Elaine Larson.
Here.
Dr. Ramanan Lakshmanarian.
Here.
Mr. Armando Nahum couldn't join us today. He had an emergency, but he was logged in earlier. Dr. Payal Patel. Dr. Paul Plummer.
Here.
Dr. Julie Simzak.
Here.
And Dr. David White.
Here.
Moving on to our liaison members, Dr. Carla Houston, representing the American Association of Extension Veterinarians.
Here.
Dr. Joni Sheftel for the American Veterinary Medical Association.
Here.
Ms. Emily Wheeler for the Biotechnology Innovation Organization.
Here.
Dr. Lisa Maragakis on behalf of HICPAC. Dr. Jim Adaskevich for Minor Crop Farmer Alliance. Dr. Jason Newland for the Pediatric Infectious Diseases Society.
Here.
Thank you. Dr. Libby Dodds-Ashley for the Society of Infectious Disease Pharmacists.
Here.
And lastly, Dr. Tim Jenks for the Wellcome Trust.
Here.
Thank you. On to our regular government employees on behalf of USDA, Dr. Jeff Silverstein.
Roxanne Macharney here for Dr. Jeff Silverstein.
Thank you for joining us, Roxanne. Dr. Sarah Tomlinson.
Chelsea Shively here on behalf of Dr. Sarah Tomlinson.
Thank you, Chelsea. Dr. Chris Robertson Hale.
Nina Anandaraman for Dr. Robertson.
Thank you, Nina. For the Department of Defense, Dr. Paige Waterman. I know she'll be joining us in and out today. HHS, Agency for Research, Healthcare, and Quality, AHRQ, Dr. Melissa Miller.
I'm here.
Thank you. For the CDC, Mr. Michael Craig.
Here.
Thank you. For CMS, Dr. Sherry Ling. Dr. Jasmine Denza, are you with us today? All right, for NIH, Dr. Dennis Dixon.
Here.
Thank you. OGA, Dr. Jose Fernandez. For ASPR, Dr. Chris Houchins.
Here.
Thank you. For FDA, Dr. Bill Flynn.
Here.
Thank you. And for the EPA, Dr. Jay Gardlin.
Here.
Thank you. Thanks for joining. All right, just a few more housekeeping items to remember. If you have a question, please be sure to use the feature on Zoom to raise your hand and you'll be called on by the moderator. Please keep your lines muted. This session is being recorded. We did that. And now we pass it over to Dr. Joni Sheftel to kick us off for the day.
Hello, everyone. Good morning. I'm Joni Sheftel. I'm the liaison from the American Veterinary Medical Association, and I'm the co-chair of the Pandemic Preparedness Work Group. Yesterday, we learned that even though we are responding to a global pandemic, we need to speak to individuals in their communities and meet them where they are. We learned the difference between guidance and guidelines. We were utterly convinced that scientists and policymakers need sociologists and communicators on the team if we want to affect change. Our science and our facts, scary as they may be, are not enough. We were reminded that pandemic preparedness needs to take a One Health approach and include a holistic perspective to be truly robust and resilient. The term One Health is bandied about a lot. One Health is not a thing. It's an approach to problems in which the health of people, animals, and the environment are all considered together. The needs and risks of each are balanced, and the outcome is optimized. And we all have to work harder to include the environmental perspective in One Health problems. Our objective today is to continue to discuss gaps in our pandemic preparedness policies, especially as it relates to antimicrobial resistance. Today, 2 panels will cover how vulnerable and marginalized populations must be better integrated into our planning before the next pandemic. We will discuss the compounding impact of health equity and access on effective pandemic response across our whole population. You can see how effective communication is inextricably linked to this and why it makes sense to include these topics both together for this meeting. Thank you and welcome to the second day of the PACCARB January 2023 public meeting.
Hi, my name is Ramanan Lakshmanarayan, and I'm co-chairing the Pandemic Preparedness Working Group with Joni Sheftel. Welcome back, everyone. So to add to what Joni said, I think we learned a lot about communications yesterday, critical to any pandemic, and AMR pandemics are really no different. And there's been a lot we've learned from the COVID pandemic about communicating during a period when science is evolving fast and keeping the public trust is critical. There were a few important takeaways from what I heard yesterday. The fact that good communications builds trust rather than the other way around is really important to keep in mind, which means that the trust building has to start well ahead of a pandemic. Professionals like veterinarians are on the ground. They enjoy trust that's been built over long periods of interaction. And again, seeing how we can systematically build that kind of trust would be helpful as a way of facilitating communications. I think although there have been some shortfalls in public trust in institutions, there are unbiased sources, including universities, that people continue to trust. And I think that we need to systematically document and look for trusted voices that can be useful at a time of critical communications. And of course, the distributional consequences are all too important, as we will see today. Children, immunocompromised patients, agricultural migrant workers, minority groups, prison populations. And I think these are areas which have been systematically ignored in previous pandemic preparedness planning around the world. And I think that we need to think very carefully about what's going to happen in these specific instances as it pertains to AMR, given that the distribution, the burden is not going to fall uniformly across all populations. So with that, welcome back to day 2, and I hand it back to Jemana to carry this forward. Thank you.
Thank you, Dr. Lakshminarayan. We're excited about today's proceedings. And actually, I'm going to turn it over to Dr. Boucher to kick us off.
Thanks so much, Jomana. Really honored to be able to chair this session with you, and we have great speakers lined up. So without much ado, I'll introduce our first speaker, and we will let the speakers all present and then have our discussion and questions at the end. So first, I'm honored to present Latanya Logan from Emory University, who's going to speak about combating antimicrobial resistance during a pandemic, the pediatric perspective, so some of our most vulnerable patients. Thanks, Latanya.
Hey, can you hear me well? Okay, great. Thank you so much for the introduction and having me. Next slide, please. Okay, sorry, I just got it. Okay, I think the first thing we'd like to start off by talking about is really some of the issues that we need to consider when we're talking about pediatric populations. In case you want to read with me, we're going to go top down. So first thing, AMR infections, we need to recognize occur in both community and healthcare settings. We need to really focus on the social determinants of health among children, the complicated process of pediatric antibiotic development and clinical trials, prioritizing kids' needs, recognizing they come in all shapes and sizes. Bed shortages, what do we do with surge capacity when your viruses are no longer seasonal? Drug shortages, formulation availability, and simple education on misuse. Optimizing quality of care and patient safety across ED and other settings. We're going to talk about taking care of hospitalized families when they're in separate facilities. How do you maintain interconnectivity? And finally, outpatient resources for children. Next slide. So some background. So multi-drug resistant bacterial infections, as the WHO has pointed out to all of you, 700,000 deaths per year globally, but I don't know that everybody recognizes that 200,000 of those are infants. So bacterial secondary and co-infections, they are going to most often occur in association with viral illnesses, so ENT, sinus, and respiratory tract pathogens. Children actually receive more antibiotics than any other type of drug. We have surges in respiratory infections that drives antibiotic shortages, and children's formulations come up in this. There are common failures to de-escalate and discontinue therapy in both inpatient and outpatient pediatric settings, and this is going to increase your risk of colonization and infection with antimicrobial resistant pathogens. Children, we know when they become colonized with MDR bacteria, do so for prolonged periods, and it's months to years, and they may become silent carriers, impacting the spread of AMR amongst all populations, and they are at risk for subsequent infection. And finally, we know that households who have children with MDRO and viruses have very high substantial transmission rates. Next slide, please. So first, community AMR infections are increasing among children. My focus is actually gram-negatives, but today we're going to really focus on these gram-positive organisms because this is what we see in bacterial and secondary and co-infections. And I just want to show you a couple things. We don't have a lot of time, but I'll focus on a couple items. So Streptococcus pneumoniae or pneumococcus is one of the common conditions that we'll see causing disease. And this is an article that really was looking at children and colonization and infection with drug-resistant pneumococci. And what you see here is these kids under 3, if you focused onto that red box on the left with 35B and F, it's cutting off for me some of the bottom. I hope you can see it. But basically at the bottom, there's a substantial amount of of resistance in this group, even to the last line carbapenems. And 35B, these are thought to have been commensal flora, but now they are being seen in invasive infections. And to my knowledge, these aren't included in the new PCV vaccines. If you move to the right, ABC core, this is a group A strep invasive infections. Group A strep we see a lot during respiratory virus season. What you can see here is year after year, there's an increase in the amount of resistance to clindamycin, erythromycin, tetracycline. This is very important because while penicillin is great for group A strep, it is some clindamycin and others we do use for invasive conditions, things that we're trying to deal with toxic shock, which we do see a lot of. And we also see issues with needing to decolonize children, particularly with invasive diseases. And if you see at the bottom, this group A strep, the pharyngitis, which is a true disease we see a ton of, there's a comparable amount of resistant infections. during that work or similar to what we see in the invasive disease. Next slide, please. I will mention briefly, just as I move on, that one of the important also things about clindamycin is that we use that often in the treatment of Staph aureus and of group A strep among children and infections. And so if there's building resistance to group A strep, you can imagine that this is a big issue for us in treatment. So I'm not going to focus a lot on this, but this is healthcare associated infections. We know these are also increasing among children. These are AR pathogens through the NHSN network. And what I just want to show you is these are multiple settings of pediatric patients. And you can see among the percent non-susceptible column that there's a substantial amount of resistance that is there amongst the gram-positive and gram-negative organisms occurring in all settings amongst these children. Next slide, please. So we can't ignore the fact that we're in this current pandemic and that we have these lessons have learned from this. And this slide is a really nice example of some of the issues of AMR and the impact that COVID has had on antimicrobial resistance. And this is not unique to kids, but I don't think that people realize that all of these things are issues that we are experiencing among the children. Next slide, please. So I think we have to spend a little time here. It's important that we really, and I know we have an afternoon of this as well, but the social determinants of health significantly impact children during the pandemic. And so starting and looking at the left, this is a very nice article that addresses some of these issues. So this is about children. So increased homelessness and housing insecurity and increased risk of viral transmission and reduced access, we've talked about. Increased food security. A lot of kids get lunches and food at schools. If they're closed, they can't do that. Reduced familial income, impact on school performance. We're still digging out of this. There's a lot of gaps that have widened. There has been an increase in abuse and child maltreatment that has occurred during the current pandemic. And finally, I want to spend a little time on this race and ethnicity issue. So if you look at the middle box, you'll see that it says that there are racial differences in antibiotic prescribing, which are occurring in pediatric primary care settings, EDs, and hospitals. And why would there be racial differences in antibiotic prescribing? Well, the answer is there should not, but there are. And if you look at this table, you can see in these common infections that we just discussed before that do require antibiotic therapy, you can see if you look at Black children, they are less likely to get these diagnoses, and they are less likely to get antibiotics prescribed for these diagnoses. So they are going to be suffering from these infections unnecessarily, and there's no good valid reason for this. As a matter of fact, some of these children get more of these infections than others. And then if you move over to the right, you can see the racial differences in pediatric sepsis recognition and sepsis outcomes. And you can see if you look down to race and ethnicity, Black children are more likely to have increased mortality and be affected by sepsis in terms of their sepsis outcomes. And again, there's absolutely no valid reason for this to occur. Next slide. So continuing on social determinants, we need to also effectively recognize that there's this decreased access to care that we experience is going to, again, disproportionately affect underserved and marginalized populations during pandemics. This includes children. One of the indirect effects of this pandemic and other pandemics is this increased risk of vaccine-presentable illnesses. And what do we see? We see increases in antibiotic uses, the co-infections from bacteria, AMR infections, hospitalization and health resources are being used, long lengths of stay, and more nosocomial infections. And another issue that we saw during this pandemic that we'll see in future pandemics, unless there's been changes that are made, is access to outpatient care for children has been limited during the pandemic. So children, and you can ask any of us who've taken care, we had difficulties getting these things for the children. They need parenteral antibiotics, biologic therapies. Where are they getting vaccines? What are their home health needs? Not everybody has resources for children. So in the middle, I just want to show you, and when the pandemic hit, vaccines plummeted as we locked down in March of 2020, and we're still digging out of this. We still have not come back to the point where kindergartners are actually getting the same amount of vaccines. There's actually been a substantial decrease in the number of children who are actually fully vaccinated entering into kindergarten, which is a huge problem. Next slide, please. So what about children with chronic conditions? There are already serious barriers to adherence, and these are certainly exacerbated by the pandemic. And you can see that red box and all of these factors that are relevant to barriers to this adherence. But underserved and marginalized communities are going to be disproportionately affected by chronic conditions. This includes children. And one of the things we need to recognize is over the last decade, there's been a serious amount of resource shifting that has occurred. Maternal child facilities are closing, and especially this is occurring in lower socioeconomic areas. These people already have job losses, transportation issues, technology issues, so they can't get to where the medicine is or their care is. And so this results in even greater disparities. And I'm not going to go into this, but just to show you how complex it is in terms of these barriers. Next slide, please. So what about emergency and outpatient facilities and readiness? And this is highly variable for children. This is where we talk about issues of equity, safety, and access. And this is the National Pediatric Readiness Project. And this is some really interesting and statements that we need to recognize here. Children are 27% of the population. They account for approximately 20% of all ED visits. But when you look at the data, 90% of these visits are occurring in local general hospitals rather than in pediatric or specialized institutions. So it's everyone's problem. And hospitals with high ED readiness scores have a fourfold lower risk of mortality for children with critical illness than those with these lower readiness scores. So thus improving pediatric readiness is going to improve outcomes for children and their families in all facilities. Next slide, please. So this is something we've obviously been seeing a lot of, this national shortage of pediatric beds that happens during the pandemic surge of infections. And this is really a byproduct of these financial decisions that have been occurring over the last decade. Pediatrics is not considered profitable, and so there's been a lot of closures. We also see during surges, staff shortages, supply and equipment shortages, even things like cribs. Seasonality has again been destroyed by the pandemic. What do you do? And then the secondary bacterial infections, which we've discussed, are increasing. So this is a nice slide from this network that talks about what care delivery maybe should look like. But I would question as to where do children fit into this scheme? Where are children among these tiers? Have we really thought about how they can actually be integrated into this model? Next slide. So we need to understand also that there's a complex process for pediatric antibiotic development, and this just has to be less complicated. If you look at this slide to the left, you look at children, the developmental changes and their physiological factors that influence their drug disposition is unique. And it is a lot that you have to consider. However, if you look at this wonderful article from the Lancet about harmonizing regulatory approval for antibiotics, we need to make it less difficult for children. We need to expedite these processes. Children need to be considered first, along with the adults. This will help us to give them what they need as soon as possible. Next slide, please. So finally, I just want to summarize and end with these considerations for combating AR through my pediatric lens. And again, reading downward. So again, we talked about we need to address the social determinants of health that worsen during pandemics. We need to focus less on this return of investment for healthcare facilities for children. Kids come in all sizes and they have special age training needs. Remember, developmental stages do not always correlate with ages. So there are different size resources and needs. Hospital readiness scores have to improve pediatric outcomes in all facilities. 90% of the kids are going to local facilities. They aren't going to pediatric facilities. It's everyone's problem. If we need to improve inpatient and outpatient antibiotic prescribing in children, we saw these differences that are occurring. We need to improve home health, outpatient infusion options, resources for children. We're going to have to invest resources in something that may infrequently or we hope never happen, but know it's coming. Improving the capacity of telehealth to address the needs of these unique and specialized children and also those with chronic conditions. We have to increase vaccination resources. We have to put mobile stations. We have to put vaccines in schools. Communities, low socioeconomic neighborhoods need more vaccine. We need to provide education. We're going to need to model more about determining these viral surges now when seasonality is no longer predictable. We have to account for staffing shortages associated with pandemic exercises, illnesses, education, the resignation that will be expected with this. Developing reciprocal arrangements is hugely important among facilities. We have to decrease the regulatory burden, and we need to be able to credential at different facilities, use the EMR at different facilities so people can affect all places. Public and private partnerships are going to be very important. We need donations of pediatric supplies, but we also need time, the space, and the equipment to do so. We have to improve strategies for family care. When there's a lot of times families are all sick at once, we need to improve the interconnectivity. They're in separate facilities. What do we do when these family members are apart? Children need their parents. And finally, we really need to improve the processes of pediatric antibiotic development, regulatory approval, and stop leaving children behind. They need to be considered first among the adults, with the adults. Next slide, please. So I'd just like to end by thanking you all for inviting me and for this invitation to speak on the behalf of children. And I would like to thank Dr. Andy Shane for her valuable input into my lecture. Thank you.
Thank you so much, Dr. Logan, for really setting the stage for the many complex issues surrounding AMR and our children and the kind of multifaceted approach that's going to be needed for solutions. So we'll look forward to more discussion at the end, but really grateful to you for being with us. We're now going to turn to Aval Nare Green from Baylor Scott and White in Texas. And I think we're going from the frying pan into the fire to talk about long-term care and COVID and the many, many lessons that it taught us, sadly, through losing so many folks. So Dr. Green, we're delighted to have you. Over to you.
Good morning. Thank you so much for the opportunity to participate on the panel. And as she said, I will be sharing the perspective of long-term care, which unfortunately was on the front lines of the pandemic. Next slide. And because I like alliteration, I'll share some pandemic pearls with you, the things that we learned in long-term care from COVID-19, the power of resilience, the interface between politics and public health, which I can tell you I was not as prepared for as I should have been. Understanding the primary vector of respiratory illnesses in long-term care, the perpetual vigilance that's needed, purposeful conversations that can be really helpful in guiding the plan of care for our elders, and then the power of partnership. Next slide. So the first pearl we'll talk about today is the power of resilience. Next slide. Now, in long-term care, folks who require long-term services and supports have often already experienced significant losses in their life. As their chronic disease burden increases, their function often decreases, necessitating the move to a long-term care facility because they lose their independence. And because they lose this independence, they will often lose connectivity with those outside of the facility. And what we learned during the pandemic is that COVID-19 compounded all of those losses. When we were in lockdown mode, we had to shut down communal dining. We had to shut down religious services. People who had an opportunity to leave the facility for subspecialty appointments were no longer able to do so. And it was incredibly devastating to our patients and to their caregivers. And what we had to do is we had to figure out how to be creative about caring. And that creative caring really provided the fuel for the resilience that we all needed. Now, I am tired of being resilient, tired of talking about resilience. However, it was beautiful to watch it unfold in the moment. Next slide. What you'll see depicted in this next slide is an example of one of the ways we attempted to bring the community into the facility. So this is a parade that we organized at the skilled nursing facility where I serve as medical director. We brought all of the care recipients out into the parking lot, gave them balloons and signs, and then invited the community to drive by in a parade. Next slide. You'll see here that we had a line over a mile long to get into this parade. Many of the caregivers and loved ones were able to decorate their cars. You can see a truck here with a mask, which I thought was quite clever. But this was really important, and I wanted to lead out with this because this is what powers our ability to make it through. This is what gave us the resilience that we needed to push through this pandemic. And these sorts of things will definitely be needed moving forward for the next one. Next slide. The second pearl I want to share with you is the interface between politics and public health. So we've talked a lot about social determinants of health, but almost prophetically, I would say in March of 2020, Daniel Dawes published a book called The Political Determinants of Health. Next slide. This is a study that looks at the determinants of COVID-19 skepticism and vaccine hesitancy, published in Biomed Central. And what you see here is a direct correlation between vaccine hesitancy and skepticism and political leanings. And what we experienced in the long-term care world is that for many of our patients, the decisions that are made about what treatments they are able to receive, those decisions are made by their loved ones and their caregivers. So for our long-term care patients, it's not necessarily their political persuasion, but the political persuasion of their adult children who are helping to guide their care. And I can tell you that we were not prepared as we were dealing with PPE shortages and staffing shortages to then also deal with the need for education, re-education, reassurance that we were all trying our best to do the right thing and to keep up with the science as it was evolving before us. Next slide. Here are some of the things I experienced on the front lines as a nursing home doctor. These are things that were said directly to me. Why are you choosing to experiment on my father? Because these drugs, when we did have therapeutics, were under an emergency use authorization, and people felt like we were experimenting on their loved ones. I had a patient who told me, my son isn't a doctor, but he acts like one, right? Because the patient wanted to be treated, but his legally authorized representative would not allow us to provide treatment for him. I want the vaccine, but my daughter won't let me get it. I will not approve treatment with Paxlovid or Molnupiravir, but if you prescribe ivermectin, I'll agree to that. Who gave you permission to test my mother for COVID? It's your fault. She's being placed in quarantine. So in addition to dealing with having these very vulnerable patients on the front line of the pandemic, we were also bombarded with having to manage a lot of the fallout from the misinformation that was circulating and still is in the public. Next slide. The next thing we learned is that the primary vector of respiratory illnesses in our long-term care setting is often those people that spend the most time with them, and it's not their families, it's us. Next slide. So we experienced shortages in long-term care before the pandemic, and they were only exacerbated by the pandemic. This is a study that looked at the prevalence of people who were working in the healthcare setting who were coming to work COVID positive, minimally symptomatic. And if you see in the last bar there, the percentage was highest in nursing homes. Many of our CNAs and nurses were working ill before the pandemic because they couldn't afford to be off. Even understanding that we were dealing with a respiratory virus, many of them would come to work with the sniffles and say, I think I just have allergies. And that, of course, was the way in which this virus was often introduced into our facilities, because at the time we were on lockdown and patients were not allowed to have visitors. Next slide. So in those moments when we were on lockdown and the only people coming into the facility were healthcare workers, we knew that when we had an outbreak, the outbreak would be because one of us introduced the virus to the facility. And that was really challenging for us. The importance of not only managing infection control when you're at work, but thinking about that all the time as you go about your day-to-day life, deciding whether or not you're going to have a birthday party for your child, deciding whether or not you're going to go to the funeral of your loved one who passed away from COVID-19. could have potentially deadly impact on the patients in the nursing home that you're caring for. Many of these frontline healthcare workers are either uninsured or underinsured, often working through illness, as I said, often underpaid, and working multiple jobs within the healthcare sector. So this was another facet to the workforce shortage. We saw in our community that there were healthcare workers who were working overtime at multiple facilities to make ends meet before the pandemic. When the pandemic hit, exacerbating the workforce shortage, we had more of that inter-facility overtime, is what I call it. So we had to be very vigilant in our facilities that our CNAs and our nurses weren't picking up extra shifts at other facilities where there was an outbreak of COVID-19 and then coming back to work at their main facility and then introducing the virus to that new facility. So we brought all of the nursing homes together and we essentially made an agreement that if our CNAs, our nurses needed to work overtime, that they would work that overtime in their own facilities so that we could try to mitigate the impact of healthcare workers crossing settings and going from facility to facility, which is very common in long-term care. Next slide. The next pearl is the perpetual vigilance that is needed. Many of us said in the first year or two of the pandemic, I can't wait until things get back to normal. Well, we're at a new normal, and it's not what it was before. Next slide. So these are some of the recommendations that have come out just this month from OIG, looking at data from nursing homes during the pandemic, where 75% of those that had outbreaks had normal infection control surveys prior to with no deficiencies. So definitely there's a need for more vigilance. Next slide. And this is also recommendations from HHS about how to reduce COVID infections in the nursing home. And some of the things that we had to do in order to make it through the pandemic, I think will persist moving forward because it enabled us to mitigate the risk of outbreaks in the nursing home. Next slide. Things like encouraging and facilitating vaccination among staff and residents, encouraging properly fitting masks at all times. I think as a physician, I will probably continue to wear masks in the nursing home regardless, because I realize that we are the primary vector. Screening visitors, point prevalence testing, social distancing, contact tracing and isolation, and better ventilation are all things that we need to continue to work on as we move forward. Next slide. Purposeful conversations. Next slide. We talk a lot about advanced care planning and the importance of that. Of course, COVID-19 brought that even more to the forefront. People were having to make decisions about end-of-life care for their loved ones that they weren't allowed to see and they weren't allowed to visit. So I found that in those instances, if I'd already had those conversations about end-of-life care, it was much easier for me to navigate some of the decision-making required when our patients did contract the virus. Because if I hadn't done that, it was very difficult for me to keep them out of the hospitals because their loved ones said, I want you to send them to the hospital. You don't have anything to offer them there at the nursing home. And so it really brought to the forefront, again, the importance of advanced care planning. Next slide. And the last pearl is the power of partnership. Next slide. This is a partnership that we were able to forge with the hospital in our backyard, in our neighborhood, when the hospital had a supply of monoclonal antibody that they were not able efficiently used because of the time required for infusion, and the regulatory pressure was lifted, allowing the hospital pharmacy to dispense monoclonal antibody to long-term care. We were able to forge a partnership to treat our elderly nursing home residents in the nursing home to keep them out of the hospital. Next slide. The partnership included our staff, the staff at the nursing home, the infusion pharmacy at the hospital preparing the medication for us, and the lab and EMS on standby for any reactions. Next slide. And during the first surge in December 2020, we were able to significantly reduce deaths and hospitalizations with treatment using bamlanivimab, because that's what we had available at the time. Next slide. During the second surge in July of 2021, we were using Regeneron at that time because the science was evolving. And the EUA had been expanded at that point for us to use Regeneron for post-exposure prophylaxis. This not only decreased deaths and hospitalizations, but it literally stopped the virus in its tracks. And we were very successful at keeping our long-term care residents out of the hospital. Next slide. So what we learned is the importance of collaboration and agility, that part of preserving hospital capacity is not only getting those patients discharged from the hospital to the nursing home when appropriate, but also treating them in place when possible. Next slide. Thank you so much for the opportunity to present, and I look forward to your questions during the Q&A.
Thank you so much, Dr. Green. That was really great and really gratifying to see those results of the treatment at the end. I think we forget, those of us who've lived through this have some PTSD, and it's really good to see those outcomes. So thank you for sharing. We're going to move on and we'll come back for discussion. I am honored to introduce now Dr. Sankar Swaminathan from University of Utah, and he's going to talk to us about integrating immunocompromised patients into pandemic preparedness. It's so nice to see you. Welcome.
Hi, thank you. So I will, you can go to the next slide, please. Yeah, so I will talk about the immunocompromised hosts, and this is pitched very broadly because there is an expanding population of people who are at particular risk during pandemics and other social and public health emergencies. We have almost 2 million new cancer diagnoses per year and over 600 deaths, and many of these are from infection. We have 40,000 organ transplants in 2021. And with the ever-increasing survival of kidney and liver and all the other organ transplants, the actual number of survivors is many times that yearly number of transplants performed. And those patients remain immunosuppressed for the remainder of their life. And now, as you've probably seen every time you turn on the television, and there are ads for immune suppressive biologics for non-malignant diseases, whether it's rheumatoid arthritis or a variety of other autoimmune diseases. So the risk of infection, morbidity, and mortality is greatly increased in this population, even under normal circumstances. Infection remains the leading cause of death still in many of these patients. And the social and economic costs of infectious diseases in these populations remains extremely high. I feel that many times we're penny wise and pound foolish. We'll spend millions on a transplant and saving someone's life, but access to relatively straightforward things that we take for granted, like dental care or a routine dose of antibiotics, is often not available in time for many of these patients. And I'm going to present a lot of problems here and questions, and I'm not claiming to have the answer to most, if any of these, but I will sort of raise them to provide a framework for thinking about how to integrate the proper care of these patients in a pandemic setting. Next, please. So prevention is, even though you would think that it would be relatively straightforward in terms of immunization, we saw during the COVID-19 pandemic that there are a lot of logistic and social barriers to implementing what we know to be optimal. So even in these high-risk patients, not only was COVID-19 vaccination inadequate, but other conventional vaccines, such as influenza and even pneumococcal vaccine, is not up to date in many of these patients. This points out a need nationally, not just for education of the patients, but many physicians, because the care that these patients receive on an ongoing basis is often not at an academic medical center or a cancer center, but from their community physicians. The immunization regimens that were recommended and were found to be necessary for immunocompromised patients during the COVID-19 pandemic were different mainly because of their impaired immune response, and the timing with respect to chemotherapy, transplant, and other immunosuppressive medications is very important. If you can get them immunized before the immunosuppression really sets in, that's critical. And much of this is, I think, to a great degree, due to a lack of consistent and clear guidance at the national level, like I said, both to healthcare providers and to patients. But in addition, even if one knows what to do, the access was often very poor. The immunocompromised patients, many of whom are mobility impaired, was difficult. They didn't know where to go to get their vaccine, and they had to call around and see if there was vaccine available. And given the importance of prevention in this population, in future pandemic settings, the availability of vaccine needs to be prioritized and made operational so that this is not a hurdle that's just left up to these patients to navigate on their own. One example is that high-dose flu vaccine, for example, which may be preferable in older patients and immunocompromised patients, is frequently not guaranteed, even at large centers. And the logistics of these post-specific regimens, in other words, I gave that example of COVID-19, they needed to have more shots and sooner, and even different types of shots. And these, I know locally at one assisted living facility, this was really in shambles until the National Guard was brought in to make this happen, and to make it happen, to get the vaccine there, to have everybody lined up, to have the paperwork done and give it to them. And we really need to have this done at a national level, particularly in facilities where many of these patients may be residing, either temporarily or chronically. Next, please. The other aspect of prevention, which I find is often not fully implemented when it should be, is, these patients don't have the luxury of being in an isolation environment. So they're often in high-risk situations because they have children at home, they have other family members who are out in the community, and they have a poor immune response to vaccination. So if there is, for example, a case of flu in the home, or when we were talking about monoclonal antibodies, these are prophylaxis regimens that can be effective even if the patient cannot be properly immunized. And to receive these prescriptions, it's the access limitation is very difficult. If you think about it, getting a prescription, even for some ampicillin or amoxicillin, is difficult for the educated person with economic resources. So I think the expansion of televisits to facilitate prescription of essential drugs is going to be very important when we have a public health emergency. And we need to think about ways in which we can deliver vaccines and drugs to patients rather than require that patients get on buses and go find a pharmacy. Another aspect of prevention that was problematic during COVID, as we saw in the early phases particularly, is PPE availability. This is particularly important for the immunosuppressed patient, where the consequences of not having adequate PPE are not quite as drastic, severe for the immunocompetent person. These patients need to know that they shouldn't be leaving their home, for example, without properly fitted masks, and the importance of air filtration at home, especially if there are people coming in and out of the home. I think this cannot be left up to the individual. There needs to be a national prioritization and plan for availability and delivery of chemotherapeutic agents, of vaccines, and PPE for these patients. Next, please. Now, diagnosis is, again, we saw this was a problem. Now, that really improved very rapidly with the wide availability of tests that could be done at home and so on. But for the immunosuppressed patients, the need for testing is often more urgent, and testing for other viruses besides the one that's operating in a pandemic, whether it be flu or COVID, is important in these patients because they can have very severe infections with other more what we think of as benign viruses. And the ability of rapid viral testing panels is currently limited. It's not available often except at high-tech medical centers. And this needs to be more widely promulgated to the practicing physician and nurse providers and so on. Now, the second point about resistance testing for diagnosis is critical. And it's not just for diagnosing the individual patient, but to know with which agent and how long to treat patients, because these patients are slow to clear. So giving them the standard regimen of treatment may or may not be effective depending on what resistance has developed. Often resistance can develop while they're on therapy because of their inability to clear the infection. And this current limitation in sequencing, not only at the individual patient level, but at the population level, is still, I think, is not as good as it could be. This is what the National Academy of Science and other committees have concluded that, and while this is improving and has improved in the US, we still see this. We saw it with monkeypox, for example. We need to decentralize the testing. Having these bottlenecks of having to wait and send testing to central facilities or even to the CDC really is not consistent with state-of-the-art care of these patients. And we know that resistance can develop and does develop in these patients from the COVID experience. And LDT stands for locally developed tests and so on. And this has often, again, been a regulatory and bureaucratic roadblock in terms of being able to do this widely. Next, please. Now, bacterial antimicrobial resistance is always a major concern, but as we see with the current resurgence of RSV and flu, is that resistance, that pneumonia is a particular problem, especially in the immunocompromised patient. And the mortality in these patients is extremely high. The high prior antibiotic exposure and colonization with antimicrobially resistant organisms means that these patients are at extremely high risk for infection, and particularly with pneumonia and sepsis with these AMR agents. The pattern of drug resistance is extremely complex in gram-negative organisms, such as some of the ones that are listed here, especially extended spectrum beta-lactamase producing organisms and other even carbapenem-resistant organisms, Pseudomonas, Acinetobacter. And we really need, not just for everybody, but for this particularly high-risk population, rapid PCR-based identification of these drug resistance patterns. And that is technically available, but that availability needs to be expanded and facilitated. Next, please. And I'll talk about why this is relevant, particularly to treatment. Now, while we have immunization for flu, and it has variable efficiency, but we do at least have the ability to mitigate severity of influenza with immunization. But we really have a very limited armamentarium when it comes to treatment of people with flu. And there's no real alternative for oseltamivir and similar drugs in the immunocompromised patient. The newest agent to come on the scene, baloxavir, which was very attractive, single dose, could be given as an outpatient. It's not currently recommended for the immunocompromised because of the rapid emergence of resistance, again linked uniquely to the inability of the patient to clear the infection on their own. And there are limited parenteral drugs. So if you have these patients who are unable to either take or absorb oral drugs, we have very limited options. And I think we need another Operation Warp Speed, not only to develop better immunization, universally active shots against flu and COVID, but we need to develop drugs, approve them under expanded use authorization, and subsidize the cost. We need to be able to treat these patients who are at such high risk of not only dying from flu, but of developing secondary antibiotic-resistant bacterial pneumonias. We need to be able to treat them before it gets to that point. Next, please. So, again, you know, I hate to sound like a broken record, but access to treatment, sometimes we have all this incredible technology in the US, but people can't get to it. The urgent care clinic is not a good model for the immunocompromised patient in particular. Just think about it. If you're immunocompromised, the last place you want to be is to be sitting in a waiting room full of a bunch of people who all have flu or COVID coughing away. We need to expand telemedicine and delivery of care to the patient. And one aspect of this is that telemedicine, if you don't pay for things, it won't happen in this country. And telemedicine needs to be properly incorporated into insurance, Medicare, Medicaid, and compensation to the providers. Because otherwise, no matter how well-intentioned they are, they're not going to be able to deliver that care to the patient. Cancer care and transplant is often insured. Like I said, you know, we're often penny wise and pound foolish, but we struggle sometimes to be able to discharge patients because the outpatient drugs are not covered. And we may be able to get the drug approved, but their Medicare or their insurance plan doesn't cover the IV setups or the help that they need to administer IV drugs at home. And this is particularly true with the new drugs for antimicrobial resistant organisms. I think one thing that, again, should be considered on a national level is a registry of patients to whom special considerations apply in this pandemic setting, because this could facilitate care delivery, outreach, finding these patients during an emergency. Next, please. So these are my final thoughts. I'm sorry if I kind of ran through here, but I wanted to make sure I covered everything. Many of these treatment decisions are extremely complex. We struggle with them even at our tertiary academic medical center with a comprehensive cancer center. The choice of antibiotics for these antimicrobially resistant gram-negative organisms is very difficult even for experts. And even the infectious disease consultants confer with each other and with national experts and with the CDC to know how to treat some of these patients. In a hospital such as ours and other academic medical centers, this is relatively easy to get that infectious disease consultation. But that is not the case for many institutions. And a telephone ID consult service nationally available would, I think, be tremendous. Some attempts were made at providing this type of assistance during COVID, but it was based on volunteers, and the people that you were asking to volunteer were already overworked and struggling just to keep their own hospitals running. So this type of thing will not be sustainable. You can't stand that up during a public health emergency. This, again, is going to require, I believe, and this is purely my opinion, that federal subsidy and payment will be essential for proper staffing of these things proactively. And I'll finish there, and I'm not sure how we're structured. I'll be happy to take questions at the appropriate time. Thank you very much for your attention.
Great. Thank you so much. Great talk. And I'll just add, as a transplant ID doc, vaccines aren't covered for our transplant patients either. And if you think about what we spend on transplants and how vaccines have a role, that's another area, along with antibiotics for complex infections. So thank you for highlighting so many of these important issues. We now have about an hour for discussion. Oh, one more presentation. So sorry. I'm just so excited about everything we've heard, and we have questions in the queue, so feel free to start lining up, council members. Our last presentation is on yet another really important vulnerable population in our country and in our world, and we're really grateful to have Ms. Julia Colburn from the CDM, or the Centro de los Derechos de la Migrante, to talk about vulnerabilities of agricultural and migrant workers during the COVID pandemic. And just as a reminder, again, after Julia's presentation, we'll have Q&A. Welcome, Julia.
Thank you. Thanks for the invitation. I'm learning so much today. It's really been a pleasure. So next slide, please. So just for some background, CDM, which is the Center for Migrants' Rights, we are working across borders, both in Mexico and the United States, and accompanying migrant workers and accessing information and resources to improve working conditions, including occupational health and safety. And since in 2020, in the context of the COVID pandemic, our health initiatives has addressed these health disparities impacting immigrant, migrant, and limited English proficient workers and their communities through targeted COVID outreach and language access campaigns. And we've been doing so with support from the CDC, from the Health Resources and Service Administration, and most recently from the Office of Minority Health as well. So in doing this, we've been really kind of working with networks, community partners, health departments, and worker leaders to bridge the gaps and build some of that trust that we've been hearing about between public health agencies and migrant worker populations employed in essential industries like animal protein processing and agriculture. So today I've been asked to discuss kind of how these communities have experienced the pandemic differently, and in particular, sort of what are the layers of complexity that migrant populations face when working at the nexus of secondary infections, so kind of between animal and agricultural products, and also in the human community. And also, what are the challenges and opportunities that we've learned that future pandemic preparedness planning should take into account? If we can go to the next slide, and please excuse some errors here, but just to kind of begin with my underlying point is that really immigrant and migrant workers are not inherently nor inevitably vulnerable to COVID-19 or to the myriad other health hazards that they face in their working environments. Really instead, just want to keep in mind that they're made vulnerable by the limitations within which they're confined to work, to communicate, and really generally to live by policies and power dynamics that can change. And we're going to talk a little bit about what we can do in that realm. So moving to the next slide, I just wanted to share some basic context on who these workers are. The first takeaway is that we're really talking about frontline food system workers, is that it's a workforce born predominantly outside of the United States, representing the full spectrum of immigration status. So that includes undocumented workers, non-immigrant workers, that's kind of the classification used, who are in the US with employer-sponsored work visas like the TN or H-2 visas. They're often working seasonally or for a short period of time. We're also see lots of immigrants and first-generation immigrants and refugees, also some legal permanent residents and naturalized citizens, and then some US-born citizens as well. We're also seeing kind of the numbers of foreign workers generally increasing as food system industries increasingly rely on foreign labor recruitment and subcontracting agencies. So in the H-2A agricultural program, for example, that's a visa program, we've seen the employer's use of that program increase nearly 600% in the past decade, while use of the TN visa program for NAFTA professionals, which also includes, animal scientists and veterinarians, has increased nearly 500%. Next slide, please. So we're also in these industries talking about an incredibly culturally and linguistically diverse workforce, even compared to other predominantly immigrant and migrant workforces in the US. So on the previous slide, we saw that an estimated 70% of farm laborers have limited English proficiency. And in meat and poultry packing plants in particular, are often places where you can find even more than a dozen languages and then dialects within those languages spoken within the same shift. Like the data we have is really not adequate to kind of capture the full range of diversity. Next slide. So just to talk about kind of how the work itself and immigration status, linguistic and cultural diversity come into play with the disproportionate health and safety risks which food system workers have been exposed historically, but also in the COVID pandemic, of course. This is protein processing and agriculture workers often work in extremely close proximity to and also very rapidly with animal and plant products, as well as the pesticides and antimicrobial agents used to treat them. So they're doing so at extraordinarily high speeds and production standards, and often in close proximity to one another as well. And so for some of these reasons, many food system industries have earned this kind of 3D reputation for demanding, dirty, and dangerous. And so kind of on the demanding side, as I mentioned, workers are often in high pressured environments. They're held to rigorous production standards that they need to meet to keep their jobs. Standardized line speeds in poultry plants, for example, are around 140 birds per minute, which can require workers to process a bird every 2 seconds. Seafood workers and agriculture workers are often paid by piece rate and may be subject to speed tests as a condition of employment. We see that especially in kind of these seasonal work programs. Veterinarians at pork production facilities can be expected to treat, which is, number of procedures, but treat between 200 and 400 pigs in any given 8-hour day, which can leave them just 1 to 2 minutes to perform multiple procedures like health inspection, vaccination, castration, wound disinfection, and antibiotic administration. So on kind of the dirty side, these high production standards can lead to corner cutting, especially when it comes to hygiene. I've talked in my line of work to hundreds, if not thousands of workers, and heard countless stories from seafood pickers and agricultural workers, not wearing masks or being incentivized to not wear masks and gloves, or not properly treating or covering wounds to avoid losing time because the process to do so or the materials will slow them down. Throughout the pandemic, we've heard in particular from meatpacking and poultry workers that social distancing was impossible. So rather than spread workers out, plants would put plastic barriers up so that workers made their jobs more difficult. Their masks would fog up and safety goggles which would make it hard for them to see. It would increase the risks for cuts and lacerations. And really, time after time, workers would report how industries' attempts to implement safety measures without adapting workspaces or line speed were ineffective or even made things worse and less safe for them. And then dangerous, we've talked about some of the dangers already, but these are industries that have long been characterized by high accident and injury and illness rates, even with chronic underreporting of these hazards. So this has certainly been true during the COVID pandemic. And I think one of the reasons I'm here today is because you're very aware that meatpacking plants were the source of some of the first major COVID-19 outbreaks. The USDA actually now estimates that these plants were a significant source of community spread in the early months of the pandemic as well, finding that counties that have meatpacking plants saw as much as 10 times as many cases as counties without them. Housing and transportation for migrant workers can also pose work-related risk factors. So it's common for seasonal and migratory workers like H2A and H2B workers, for example, to live in employer-provided group housing, which in the pandemic have often failed to meet public health standards for social distancing, ventilation, and isolation. And then despite the disproportionate risks that workers are facing, the oversight from state and federal agencies responsible for enforcing health standards has been, historically lacking in these industries as well, and is even worsened during the COVID pandemic as agencies remove field inspection workers and court shutdown, among other things. I've also added just a quick isolated to the 3D list, an eye down there at the bottom, which is that food workers in food system industries are often very rural, increasingly rural, which for workers poses additional barriers to communication, transportation, access to support services like healthcare and legal support. Next slide, please. So immigration status, can put workers at further risk for health and safety hazards for a number of reasons. We've heard workers routinely express well-founded fears that reporting an injury or illness could cause them to lose their job or to be reported to immigration authorities. And at CDM, we've witnessed countless examples in which whistleblowers were subject to retaliation for speaking up about unsafe conditions or taking time off of work because they were sick. And countless others were examples where workers chose to remain silent or continue to go to work while sick. So work visas do not necessarily provide migrant workers with additional protections. And if you take the case featured here of Reina and Maribel, they were working at a crawfish plant in Louisiana as part of the H-2B visa program when COVID broke out at the plant in 2020. When they became seriously ill and sought medical care at a hospital, their employer retaliated, costing them their jobs, their housing, and their immigration status. So under the terms of that visa, losing their job meant an immediate return to Mexico, leaving impossibly limited time and resources for them to take legal action or even to file a whistleblower complaint with OSHA. So immigrant and migrant workers really are also, across the board, more likely to mistrust and avoid government agencies, especially in the context of anti-immigration policy making and enforcement actions. And as you may know, that some of the largest immigration raids in the past decade and a half have targeted protein processing facilities and have even shaped really generations of workers in these communities and far beyond. So you can see why, having the uniformed National Guard operating mass vaccination clinics in 2021 was a deterrent for some of these communities, even if they were, among the first to be eligible for vaccination. And finally, immigrant workers, especially undocumented and seasonal workers, are more likely to be uninsured or underinsured and are less likely to have a primary care physician and are less likely to report to, therefore, or seek treatment within formal healthcare institutions. Next slide, please. I'm going to just pass over this quick for the interest of time, but in 2021, we conducted a survey among protein processing workers on some of these issues I've just discussed. I won't go into depth on the findings, but it provides some greater context on experiences that migrant workers have experienced during COVID and, within these industries. So the link kind of provided below can take you to the more in-depth report. Next slide, please. So again, when it comes to taking action on these health and safety concerns, language is another limiting factor for workers when those government institutions that are responsible for their workers and the general public's well-being are inadequately equipped to handle workforce's diverse linguistic and cultural needs. So as an organization that's dedicated substantial time trying to bridge gaps between immigrant and migrant workers, health departments, and other government agencies, I can tell you that many agencies will be the first to say that they themselves have insufficient or absent language access policies or insufficient resources to implement them. That they also have to resort to one-size-fits-all approaches like standardized translations that are disconnected from local vocabularies and contexts of these communities, that they have limited exposure to and weak connections with immigrant and migrant communities and aren't regularly involving these communities in planning and implementation of programs. And while these agencies may value and rely on community-based organizations to help bridge those connections with communities, many just don't have the adequate funding to sustain the partnerships long term. So in many cases, federal COVID-19 funding has really strengthened these community connections and made important progress to closing health equity gaps. And these are connections that could be leveraged for many other public health matters beyond COVID-19, but are instead of being sustained and expanded, they are currently drying up. Next slide, please. And again, this is just another clip from that survey that I'll ask to skip in the interest of time. Next slide, please. So kind of wrapping up here, in addition to laying out the problems and layers of complexity that shape food system workers' experiences, I was also asked to discuss, where immigrant and migrant workers and where organizations like mine need support to help workers work safely and what future pandemic and preparedness planning should take into account. So, from where CDM stands, it's really fundamentally clear that to better protect this population and society at large, future pandemic preparedness planning and public health approaches like One Health we've heard or social determinants of health must necessarily take into account that occupational health is public health, and we must integrate strategies to address the working and immigration conditions that have made workers disproportionately vulnerable to COVID-19 and contributed to community spread. So changing the structures underlying these inequities is a long-term and complex battle, but if we can turn to the next slide, I've listed some preliminary recommendations for consideration. So first and foremost, government agencies can and must absolutely prioritize the participation of immigrant and migrant workers at all levels of policy and intervention design and implementation. So workers are the experts on their experiences. They know what best they need. The workers pictured here, for example, are members of an advisory committee formed to inform COVID response on our project and feedback to CDC. This past year, we've also helped facilitate listening sessions, similar kind of to this one, with agencies like the Department of Labor involving workers and worker-led organizations. Federal government agencies can also help diminish the power of immigration and labor-related retaliation by strengthening and expanding protections for whistleblowers and disseminating information about existing protections. So I'm really excited to report that just over a week ago, the prospects for immigrant and migrant whistleblowers involved in labor disputes changed dramatically. The Department of Homeland Security emitted new deferred action guidance, which through this announcement, undocumented workers and workers on temporary work visas who either experience or witness to labor violations at their work sites can now report these violations to federal and state labor agencies, and with the support of those agencies, receive protection from deportation and access to work authorization. So this is really good news for occupational health and safety whistleblowers, and it would have made a difference, to workers like Maribel and Reina, who you mentioned earlier. And at CDM, we also wonder whether this mechanism could be extended to whistleblowers witness to food safety, animal mistreatment, or other violations of the Food Safety Modernization Act. Next slide, please. Other critical cross-cutting measures ensuring that all public health, labor rights, and really any agencies with responsibility to limited English proficient communities are equipped with adequate language access plans and implementation resources. Language access is not only a best practice, it's also a law, established both within Title VI of the Civil Rights Act of 1964 and Section 1557 of the Affordable Care Act. We're currently operating pilot programs with cohorts of local health departments in the East Coast to support the development and implementation of these kinds of plans. To further close gaps and build trust with immigrant and migrant communities, agencies can also fund sustainable private-public partnerships between government and community-based organizations, like ones that have been so successful in the COVID-19 pandemic. But, as I mentioned, are in the process of expiring. The cooperative agreements that the CDC established with community-based partners are one example of a best practice there. These are infrastructures that could be leveraged for any number of other health priorities. And finally, given the barriers that workers face to affordable healthcare and insurance, and given the inadequate availability of paid sick leave for most food system workers, but especially for informally employed, seasonal, or subcontracted workers, there's also a need to expand access to both of these measures to workers regardless of status, immigration status, and in alignment with occupational and public health priorities, not production standards and profit. This also means better outreach to those currently eligible for healthcare coverage, access to multilingual telehealth services, streamlined and more flexible enrollment. And it also includes, of course, guaranteed free testing, treatment, and vaccines for COVID-19 and other infectious diseases. So last slide is just my contact information. I look forward to continuing the discussion.
Great. Thank you so much, Ms. Coburn. And wow, we've heard about 4 really vulnerable populations. So children, long-term care residents, immunocompromised people, and agricultural and migrant workers. And I'm struck already by some of the themes and the presenteeism issue. So many of us are used to dealing with the presenteeism issue as a risk to our patients. But we just heard about how presenteeism is a risk to people's very existence. And I think that it's really humbling going into the, 4th year now that we know it's a problem, but we can't fix it. So I'm really looking forward to the discussion and some creative ideas from this group. And I'm just going to go by the list that I have and just ask folks to raise your hand and we'll recognize you. So we'll start with Dr. Blazer.
Great. Thanks so much, Helen. And thank you to the panel. What an interesting panel. And it's so informative for us and I hope for each other. I would like to direct my question to Dr. Green, but it's really to everybody because this issue about politics and public health is not a new issue. In fact, I was just looking it up. In 1882, the Norwegian playwright Henrik Ibsen wrote a play, An Enemy of the People, about the clash between public health and business. And of course, it's a classic play, and it keeps coming up at all. So the point is that public health always exists within the orbit of political consideration. And I think as professionals, we've been naive about it. We've been naive and COVID has kind of slapped us in the face. But we need to prepare for the next pandemic. We need to prepare in general. And your slide about trust in vaccines and political viewpoints, that kind of linear graph, also was very informative. Not surprising, by the way, but very informative because it means that the approaches in different localities have to be different. It's not one size won't fit all. And that's where the communication is so important. And, I think your work suggests that in every locality, there are people in the political realm who do champion public health in every locality. We have to find them and we have to make connection with them so that when the pandemic arises, there's somebody in our community who's well trusted, well established, who can kind of be a basis. So I wonder if you could comment about this point.
Yes, thank you so much for that question. I think you're right. We've been naive. I don't remember significant discussions in my medical school training about navigating those waters. One of the things that I think is really important for those in long-term care is for us to better establish decision-making capacity, even for those people who have some degree of cognitive impairment. So, for example, I may be caring for someone who can't remember what they had for breakfast in the morning, but they still value preventative medicine. They still want their flu shot and they want preventative medicine. So if we have labeled them as cognitively impaired, and then by virtue of connection, lacking decision-making capacity, then those folks are sort of at the whim of whoever their legally authorized representative is. So what I try to implement in my facility is more assessment of not just cognition, but decision-making capacity specifically related to preventative care, because capacity is situational. Right. And so I think that nuanced work is really important because from a regulatory standpoint, we've got to document that cognitive impairment is present, but we don't necessarily take the next step and document decision-making capacity.
Yeah, great point. Thanks very much. Dr. Laxminarayan?
Thank you. I have to say, in the 22 sittings that we've had of PACCARB, I can't recall a session that was quite as powerful as this one. And I feel like it's sad that we've arrived to it so late after having gone through many discussions, not only in the context of pandemic preparedness, although these should all be AMR issues that we should have really dealt with a long time ago. But better late than never, and I'm glad that we got around to it. So my questions are twofold. One is for Dr. Latanya Logan. So you talked about the hospital ED readiness scores, which seem to have a significant impact on pediatric outcomes. So are these pediatric-specific readiness scores? Are they more general? Are the peds more affected by these scores? And the broader question, I guess, to all the speakers is, are there other similar readiness scores that would allow us to measure how prepared we are for an AMR outbreak for other vulnerable populations? In other words, what gets measured gets influenced, and then something happens to it. If we're not measuring appropriately, then we're not doing the right thing as far as preparedness goes. Do we have these kinds of preparedness scores for, say how we're dealing with migrant health, for instance, or with immunocompromised patients, and are we implementing these? And my second point was for Ms. Coburn. I really had not appreciated how much One Health is a relevant lens for the health populations that are working closely with animal food processing. And of course, if these are also the folks who have the least access to healthcare, we're both putting animals at risk by being handled by migrant workers without healthcare, but also migrant workers at risk because of the risks associated with being close to sick animals. And it's clear that occupational health, as you made very clear, is One Health. And it's something we need to embed into our thinking, again, beyond pandemic preparedness, but much more generally into how we think about One Health. So thanks for bringing that to our attention.
Thanks so much for the question. In regards to the Pediatric Readiness Project, that is specific to the Pediatric Readiness Score. So those were really those who deal our facilities, and the group is a collection of many people, but a lot of emergency departments and outpatient facilities, and those who look at readiness and preparedness amongst that population. So while the readiness score for pediatrics is specific to pediatrics, I do believe that there are readiness scores that have been discussed for other populations, but I will leave that to the other panelists to say. So, just to be clear, so when I say that there's that fourfold reduction in readiness, it really does reflect those hospitals taking care of pediatrics, whether they're adults or children.
Great. Thanks. Do the other panelists want to chime in on any of Ramanand's comments?
I can jump in really quickly, just, kind of on the first point about preparedness measures. I don't have a lot of data, but I can confidently say that data on immigrant and migrant populations in general is very, very lacking for some obvious reasons. Folks have spent lots of time trying to avoid detection and formal documentation for members, or been incentivized away from that. And one of the things that we've been trying to advocate for, and again, I had to limit my time, but is better data, and also better data and communication on the relationship between infectious disease spread in occupational settings. So in the COVID pandemic, and kind of its relationship to community spread and sort of the broad. That was something that was really not available, certainly not systematically, and that health departments told us routinely that they were unable or unwilling to track or share. And just sort of on the point about in the risk between animal and humans, kind of and in these agricultural settings where folks are working so closely and so fast, that is something certainly that we've seen. I had one brief anecdote too from a veterinarian with a TN visa working, one of the vaccinating and doing a number of procedures in a matter of a minute or two for hundreds of pigs a day, had detected a roundworm parasite at one of her work sites that does have human transmission, and was essentially retaliated against for reporting that to management and requesting treatment for herself. She and another coworker were able to get it kind of surreptitiously, but the rest of her coworkers were not. And that's something that, is repeated time and time again in lots of industries, but not documented.
Thank you. Dr. Cray?
Yes, thank you very much. As many of us are living essentially what is now a long-term nightmare for long-term care of parents and others in nursing facilities, this is particularly directed to Dr. Green and is twofold. One, what do we know about long COVID in these populations? I've not heard anything, and then I have a follow-up question after this.
Thank you for that question. So our elderly patients are not immune from long COVID. And one of the challenges is that many of them are already experiencing symptoms that you would see with long COVID just by virtue of aging with chronic comorbid illnesses. And so what often happens, as is true with ageism in general, is that those symptoms get overlooked because it's lumped into, well, she's 85. What do you expect? And that's why we don't know a lot about it, because we're not identifying it. We may be seeing it, but we're calling it something else. Now, I've been incredibly shocked at how some of my patients have bounced back. I've also been shocked by how some of them have not. And I'm finding it challenging to predict who will bounce back and who will not. I've even had some folks who were on hospice contract COVID-19, survive that, and then continue to live for several months with some improvement from their time when they were acutely ill. So very difficult to predict who's going to have symptoms, extended symptoms, and very difficult to identify those that are due to long COVID because there's so much overlap between the symptoms associated with aging with chronic conditions.
Thank you very much. This is something I've wondered about, just having just enough information to know to look and observe differences that may be going on, and not having the power to implement any change. And that brings me to my second point. So I was, so for the last several years, I receive sometimes 3 or more times a week a notice from a care facility where a family member is that either a resident or a staff member has COVID. And then they go through the, we'll implement the policies of signing in, going through all of the hand washing, masking, limiting visits. And I was just struck this week by a call from the care facility after several weeks of not hearing anything and being very happy that a new staff member was identified as COVID positive, and precautionary measures should be taken. That was it. And I thought, for the turnover and as many new people coming in, and that was really scary, because I thought that now people are going to become more lax. And if anything, I would encourage you to take that presentation that you gave us, put it on YouTube, add this part about continuing precautionary principles, and send it to every care facility or make it available, because it is, your presentation was extremely powerful. And I have a concern that these facilities now are going to, they've just suffered fatigue enough that they're done.
Yeah, I appreciate that comment. You're absolutely right about that. And unfortunately, because we are so heavily regulated, there's fatigue about being regulated.
Yeah.
So we've got to be smart about the things that we require of folks in post-acute and long-term care. There are some things that we've implemented in our facility that are not required of us, but I believe are good medicine. So for example, we still have someone sitting in the lobby, checking temperatures and getting folks to sign in, handing them a mask. We are still requiring COVID swabs before anyone new comes into the facility. And if it's a resident, they all go on our warm haul until we have verified their vaccination status and we've gotten a repeat COVID test. Then they're allowed to move out into the facility and go to therapy and those sorts of things. That's not being required of me, but I believe that's good medicine based on what we've lived through for the last 3 years. I would much rather get a break on survey items like cleaning the windows and, some of these other esoteric things that nursing homes are regulated on, and have more support and structure around the way we prevent outbreaks and mitigate the risk of respiratory viruses in the nursing home.
Thank you very much. It was an outstanding presentation.
Great, thanks. Dr. Ginocchio.
Okay, thank you. What a great session, extremely interesting. My question is directed towards Dr. Sankar. And first, I'd really like to thank you for addressing issues relating to diagnostics. And I think that's a really key element in everything that we need to do. I think what we don't fully appreciate is that the availability of viral panels, comprehensive viral panels in the outpatient setting is there. We have ClearWave tests, but it's really strictly limited by the current reimbursement policies that we have in the outpatient setting. As been an ID lab director for 40 plus years and a member of the IDSA Diagnostics Committee, we have fought this battle long and hard with the payers for a lot of years. We've written policy statements, and we're not looking at reimbursement for all cases. We truly believe in diagnostic stewardship, but yet in certain at-risk populations, and one of the ones that we particularly have always carved out have been the immunocompromised patients, where more comprehensive diagnostics should be available and they should be paid for. But despite all these efforts, we still see reimbursement refusal. And if they do allow it, they make the ability to get a test so impossible by requiring all these pre-approvals. You have a patient in front of you, you're not going to wait 2 days to get approval to do a comprehensive diagnostic in the outpatient setting. So, a lot of these efforts have were put on the hold during the pandemic because we kind of had bigger fish to fry during the last couple of years. But how do you think we can use these experiences now that we've had during the pandemic and the lack of ability in these at-risk populations, whether it be immunocompromised patients, whether it be children with cystic fibrosis, whether it be other debilitating conditions? The reimbursement for these tests have come down to very reasonable prices now, but yet we still get such pushback from the payers to approve these tests in the outpatient setting. So what lessons learned that you have from the pandemic could we now use to, again, reapproach the payers to get them rethink this so that this testing becomes more available?
I guess if I knew the answer to that, I would be the president of the United States. But, you're asking me a question that's inherently political and economic rather than medical. And so what I'm going to say is really a personal opinion rather than one where I can claim, factual expertise. But if you look at the position of many countries where this is not so much of an issue, I've talked to some transplant ID physicians in Canada, for example, and they don't have as much of a problem with this. And it's because their institutions have allocations. And, you know, based on the number of transplants that they do, based on the number of leukemia patients that they see, and it's done on a macro level rather than on an individual level of, does this patient deserve a test? Mm-hmm. And it's up to the institution to husband their resources and use the allocation that they have. And they can then develop their own priorities and do that. And you know, these structures and positions that are derided as being socialist or communist in this country are really right of center in most Western European nations. And I think there has to be central planning and funding, and that is not a bad word, and it's not communism. It's just common sense. Mm-hmm. You cannot, you know, make these decisions on deciding on a granular level whether this patient deserves a test and then go through a pre-authorization process for every. It's just it's inefficient if not mm-hmm. medically ill-advised. Mm-hmm. Yeah. So I think this is above, in many ways, unfortunately, our pay grade as physicians. We can advocate, we can lobby, but this has to come down in terms of national resource allocation.
Yeah, great points. And, you know, I might just add a note that we think about the resource allocation of the precious organ. This is part of that discussion too, right? We spend $500,000, even $1 million to implant certain organs in our patients, and yet don't think holistically about things like diagnostics. So it's a great point.
I mean, anecdotes are often powerful, even if they're not scientifically valid, but I'll never forget this patient who had a liver transplant, and he had been doing well at home, and his immunosuppressive medications were paid for, and he was on Medicaid. And he was admitted with sepsis and was found to have endocarditis. And he ended up, you know, it was a decision as to whether or not he could withstand valve replacement surgery. He had that and extended antibiotics and an extended hospital stay. And then, of course, chronic rehabilitation, probably cost $1 million. And you know why? It's because he couldn't go to the dentist. He could not afford a $60 prophylactic dental visit. And his mouth was full of rotten teeth. And this is an example of how the care of these patients needs to be comprehensive.
Mm-hmm. Yeah, great point. Well, in the interest of time, I'm going to move us along because we have a lot of people who have thoughts. Dr. Fact.
These are really thought-provoking presentations, all of them, and areas that I know very little about. And so I have lots of questions, but sort of a specific question related to some of the things we heard about yesterday about communication during a pandemic. Dr. Green, could you share what your experience was during the pandemic, early, middle, or late, about what guidances you used, applied, didn't apply, ignored, considered? We heard yesterday from Dr. Chan and from New Hampshire Public Health, who talked about, you know, how many different, there are state guidances and federal and, you know, local, and of course, whatever long-term care. So could you talk a little bit about how you manage that and what you paid the most attention to and that sort of thing?
Yeah, I told folks, whatever I tell you today may be wrong tomorrow, but this is what we're going to do today because things were moving so quickly. So I had the CDC COCA calls, you know, loaded onto my computer, referred to them very often. We also had a website where we could get updated prevalence for our community so that we would know whether we were red, yellow, or green, because that determined what kind of mitigation efforts we had to put into place. It was very challenging because the updates were coming from so many different places. We really just sort of crowdsourced that, and we were all sort of watching different channels and then sending out information to each other. But I would say the CDC and the state website that showed us what the prevalence was in the county were the two main places I looked. And then, of course, our hospital was sending out daily numbers so that we would know what capacity was in the hospital. Because if the hospital was full, that meant that whatever I had going on in the nursing home, I was going to have to find a way to take care of that. So I guess local hospital, county, CDC were my main go-tos.
Great. Thank you, Dr. Green. Dr. Carricker.
Well, I want to thank all the panelists for the information. It really has been an eye-opening session, but especially want to thank Julia Coburn and the information about the plight of some of the migrant workers that work in these systems. And I always ask my students who feel overwhelmed and compressed for time, you know, what would you be willing to give up if you had to spend the time to raise your own food? And I think it's important to keep that in context and be thankful for the work people do for our benefit in that respect. I wanted to ask about a fairly horrific anecdote that you shared there about the plight of some workers on a farm, and that was sort of mixed in with activities in the plant and on the farm, and I might have got that a little mixed up, but it was counter to my direct observations for over 20 years in pig farms. And so my question for you is, how do we get a broader representative picture of what all of these specific employees endure so that we can appropriately direct intervention? If we extrapolate that anecdote to every farm, then it looks like the solution is dealing with the industry as a whole, and we could direct a lot of effort without a lot of result at that, when maybe the solution is seeking out and retraining or potentially removing supervisors who would behave in that manner, for example. So I'm curious about your thoughts on how we get a broader representation of how often these type abuses occur and how we figure out where best to target intervention.
That's a great question. And I think that's something that we've been, ourselves trying to do. The anecdote I was sharing was, this is, I would say, contextually, kind of a specialty of CDM, a unique niche that we found ourselves in by virtue of being kind of a binational organization, is working with especially seasonal populations and those kind of populations that are increasingly contracted with the use of kind of seasonal visa programs. So the TN was one I was mentioning, and when I was talking about animal scientists, veterinarians who are increasingly employed kind of as caregivers or in animal husbandry, throughout that, the live animal or the animal's life. And we don't have a lot of data on where they are, who they're working with. It's hard to know if the anecdotes that are being shared from workers that we've seen repeatedly and tried to document. We've had some reports also on kind of some of the patterns that we've seen. And again, trying to look at the structures there, that visa program doesn't have regulations really. There's in the way that even H-2A and H-2B do. And I think, there's some deficiency there that we would point to in kind of the advocacy world that we've been pushing to change. But with the TN visa, there's nothing. There's not even guidance for workers on kind of what their rights are, what their contracts, and whether their contracts are valid or not. It's very, very kind of under off the record process, very informal, but it's growing, and we know that. And we know that companies are turning to kind of workers within these visas for a reason. One of those reasons may be that they're highly exploitable, that they're tied to work with them, and that creates unique and vulnerabilities that can be attractive to exploit if there's really no consequence. So I think we've pointed to those visa programs as especially important opportunities for intervention, for analysis, for understanding, but want to empower workers generally to come forward. So these kind of mechanisms, the deferred action that I was mentioning, we're really hoping that this is going to encourage a lot of folks who haven't been able to speak up to participate in things like studies, to make whistleblower complaints. We'll get more data and evidence as well, kind of through their stories, if we know who they are and what they're going through. But right now, and kind of in history, it's been very, very difficult to get close to those folks. So I don't know if that's a fully satisfactory question. I think we're looking to answer that as well. But we do have on record, and we do have lots of cases documenting that these are taking place, not just in isolated industries, but rather in, isolated workplaces because of a bad apple supervisor, but something that is more widespread and points to some of the structures within which workers are being recruited and employed.
I think it'd be my perception that if you approach it in that way, you're probably likely going to get more cooperation than you think. Often these employees, because of licensing requirements and things like that, they're actually working at levels that they're somewhat overqualified for in terms of their training in other countries. And so they elevate the level of animal care, and they're highly valued as employees. And so I think companies and organizations would be interested in mechanisms that would make them feel more valued and would do a better job of finding ways for them to be successful in the organization generally. So I think with that approach, you'll probably find more cooperation, maybe even than you anticipate.
I would hope so. I would say that our experience so far has been a little bit the opposite, where we've just heard folks being consistently undervalued and being used to kind of in the TN program in particular, in place of H2A workers that, of course, can only be employed in seasonal industries, but where animals are involved, that seasonality requirement is not being met. But the TN visa is a way to bring in folks to do kind of, the quote unquote unskilled. I would never call these jobs truly unskilled, but they're classified as so, but kind of as almost as a loophole. And again, I think there's some patterns where we're seeing this is growing. I do remain optimistic though, that's why I'm in this work, that there are ways to kind of work together and overcome some of these challenges that we're seeing.
Great, thank you. Dr. Newland, nice to see you.
Nice to see you, Helen. Thank you. Dr. Shea, thank you. Obviously, as many in the council would probably know, I got pretty excited when I saw Dr. LaTanya Logan on the agenda. I hope people realize you obviously saw an amazing presentation, but, before Dr. Logan went to Atlanta, she was one of the many unsung heroes of the COVID-19 pandemic response, leading one of the major universities and medical centers in Chicago for this response. Epidemiologist, researcher, clinician, she does it all. And so for that, I want to thank you. Thank you for being a leader for pediatric health and staff and others. My question, and you touched on it, was regarding access. You talked about this, many children don't have what you would say access to the best care, and discussed that in a previous question. And I would say that as I look further and further, we have a lot of access problems when it's come to the pandemic, whether it was, one might say, in-person schooling or effective virtual learning. One might say to the COVID vaccine, right? A family of 4 with 3 different, 5 with 3 different kids, 3 different ages, had to get 3 different doses, and frankly, couldn't go to one place for all of them to get vaccinated. So I'd just like to hear your thoughts. I think you mentioned some things about using schools and others. How do we improve access for children and health and education? It seems like, for me, we sometimes forget that while we live in this amazing country, we don't actually provide the access that everybody, and again, from the social determinants of health perspective as well, to get what people need, especially our children.
Thanks, Dr. Newland, for that warm statement. I feel the same way about you, but I'll keep it brief. I know there's a lot of questions. And I see Dr. Black on here, who was a huge, amazing person in this response that we had in Chicago before I moved to Emory. And what I will say about this, and this is a very difficult issue, right? It's a difficult issue because we're talking about this intersection with children who also have family members who also have these struggles, right? So your child is not going to be able to go to school because maybe they have to work, or the parent isn't able to facilitate, doing work from home or telehealth, or they're essential workers, right? These are the children who are born to them, and they have to leave. And so the children are affected from school performance, and we're going to be digging out of this disparity, what we're seeing from those children who were not given those resources to go to school during the time where they were at home, or when they were back in school, those schools still didn't have any resources to teach them or properly. We're going to dig out of this for decades. But what I will say from an access standpoint that really is disturbing is this had started again before this pandemic. This closure of the pediatric facilities and the maternal child facilities, the labor and delivery units, full children's hospitals are closing. Why? Because we're not profitable. Is that the way we need to look at children? We can't look at children under a lens of profit, right? We're looking at them in terms of the lens of need and vulnerability and what we should be doing for everyone, especially for our youngest and who is going to be taking over for us eventually. I think that one of the biggest things that we have to rely on, like we did with the Chicago Department of Public Health, is this public-private partnership. We found ways when we worked together to bring access to these communities in a meaningful way. So we needed to use donations. We didn't rely on just federal or state assistance. We relied on churches. We relied on barbershops. We relied on other community members who are trusted to get these resources to our children and to those families because they have no other way to get there. But these places are in these communities where there are no health facilities. So if we can use structures like we did, and Dr. Black can comment, where we were in schools, we were in gymnasiums, we were vaccinating, knocking on people's doors to give them vaccines at their front door. You have to meet the people where the need is. And I think that is where there's this conundrum, because every state and health facility is different, but we need to start looking at them under that lens of bringing this all to the people.
Great points, Dr. Logan. Dr. Dinsta, welcome.
Yes, hi, thank you for the great presentations. And mine is more of a comment regarding Dr. Swaminathan's talk about the Medicare coverage. Of the vaccinations, and I just wanted to remind everybody how the Medicare covers the vaccines. So the Part B vaccines, Medicare Part B covers vaccines for flu, pneumonia, hepatitis B for individuals at high and intermediate risk, and COVID-19, and certain reasonable and necessary vaccines to treat an injury or exposure to a disease. That means if you get a cut and you need a tetanus shot, that is Part B. But if you get it as a preventive measures, that is a Part D. And the Part D covers almost all the vaccines which are not covered by Part B. And starting in 2023, patients with Medicare drug plans will pay nothing out of pocket for adult vaccines recommended by Advisory Committee on Immunization Practices. Part 5, Section 11401 of the Inflation Reduction Act of 2022 requires these vaccines to be free to the patients and makes Part D vaccine cost sharing consistent with coverage under Part B, where the patient has no co-insurance or deductible. I hope that helps. Thank you.
Yeah, thanks very much for the clarification. I think where there may be an opportunity is in those ACIP guidelines for immunocompromised people, especially transplant recipients and transplant candidates, right? That's who we want to vaccinate. So I know the transplant societies and others are working on this, but as we think about solutions, it's important, I think, to highlight some of these things that are really good medicine and good prevention. Dr. Simsak, nice to see you.
Hi, thank you so much. And really thank you to the panel. These were incredibly informative and powerful presentations. So I have a lot of questions and ideas, but I think there's a central one that keeps coming to me as I'm thinking about our task order and the recommendations that we need to make about the federal response to this kind of crisis situation. I'm thinking specifically about a theme that emerged first yesterday, but I think came up throughout this panel, but I think most explicitly stated by Dr. Swaminathan's presentation, is the tension between individual responsibility and what responsibility we as the collective has to consider, sacrifice for, and really work to protect the most vulnerable among us, who may not have the capacity, either based on structural constraints or other capacity limiting situations, to exercise that personal responsibility or use the evidence-based tools that we know work, right, that science has shown work. And obviously this is a political, economic, cultural, and frankly moral question about what we owe each other, and it obviously doesn't have an easy answer, but it's one I don't think we can ignore as a panel and as a council. And so while we can't, I'm not asking the panelists to answer that. I think we did hear specific actions or approaches that may be something we should consider. So particularly a patient registry. I thought that was a very interesting idea about a registry to disseminate information and resources. We heard about telehealth technologies and the role that novel technologies and innovations might play in helping access those who are having trouble getting what they need. Even community engagement, or sort of meeting people in their social networks where they already are. And I'm wondering if the panelists can identify any more ideas like that, or other techniques, or say more about those ideas that we might consider as, you know, concrete solutions that are obviously not going to solve the problem or the political problem of public health, but that can help address the fact that some people in this country, by virtue of things out of their control, cannot access the tools we know keep them healthy. Thank you.
So I could make one comment that occurred to me. You know, my talk focused a lot on physicians and high tech and, you know, genomic sequencing and so on, but the sort of real structural impediments have a lot to do more with the socioeconomic situation and the fact that this is a very large country and transportation is a real problem. We have patients who are immunocompromised who can't travel from where they live in places like Wyoming and Montana because they're basically snowed in. And, you know, I didn't really talk about the importance of caseworkers and nurses and PAs and so on. And it should be possible to, you know, other countries, and it's quite efficient and not that expensive compared to what we do, is to have healthcare providers go to people's homes. And, you know, that a nurse whom you know who comes to your house is probably worth a lot of infectious disease professors in terms of practical effect. And it doesn't matter if you buy iPads for all these people. They're 70 years old and they can't, you know, they couldn't program a VCR. They're not going to use an iPad very well. Okay. And you need somebody to go to their house and sit with them and maybe, you know, just bring the low-tech medicine that's so important to their home. And this is the kind of thing that I think it's something that, again, at a national level, if you can identify the patients who are in most need of these services, you know, our Ryan White program, with the small amount of money that we have, I think accomplishes a great deal in this kind of thing. We have a lot more case managers, mostly to deal with the bureaucracy, but also to provide medical care than we do doctors. And I think it's a very efficient use of resources.
I think that is an excellent point, and I will say that our Division of Geriatrics here in Central Texas at Baylor Scott & White spans the continuum and includes a house calls program. And so we drive around with influenza vaccines. We have not been able to deliver COVID vaccines since the first part of the rollout, just due to the sheer logistics of it. However, we've got a contact at our area agency on aging. We give that to families, ask them to call while we're present to schedule that vaccine in the home. Was so excited to hear Dr. Logan talking about knocking on doors. I've got a really soft spot in my heart for home-based primary care and home-based preventative care, right? So I think getting the care to people where they live is the best way to do it, because if they can't get to the care, They will only come after the wheels fall off and the yarn unravels and they're in crisis mode.
And I just would add, you have to remind yourselves that they have to be able to trust you. So having those trusted people with you when you're doing this is just worth 1,000 ID professors, right? And just remembering also that these people need specialized training to deal with not just, from 0 to, 100 and plus. We need to be able to be trained to deal with all populations. And I think that's where we fell short in this particular pandemic.
Great points. Thank you all. Dr. Black?
Yeah. As everybody has said, thank you for this fantastic panel. And I have so much to say to all of you. I'm going to focus my question for Julia Coburn, but I do wanted to say, Dr. Blazer had pointed out that in every locale, we need people who champion public health. And I do want to remind folks that their local and state public health departments are really invested in doing that. And so through funding from CDC, the healthcare associated infections, antibiotic resistant funding, we have been able to engage long-term care facilities. And so Dr. Green, I really want to thank you for all of your work, because it's people like you on the ground at those facilities making these guidances and constantly updating, the follow through on that is so essential. So I want to thank you. And I also to Dr. Logan, a shout out for being also a partner and really champion of exchanging communication about those iterative guidances. So, we have lenses, I feel like, into the healthcare facilities, but I do feel like, in my question to Julia Coburn, is really how we can engage on a local public health level more with you, especially in light of the current, humanitarian crisis that's happening with migrants. But during monkeypox, we really engaged with the LGBTQ community about, how we can connect, how can we connect both on a communications messaging level and then also access to care. And I'm just wondering, I want to know if you have like a local branch in Chicago, but we can talk about that offline, but just how can public health engage more in terms of both the messaging, making people feel comfortable, and then also the access to care and really engaging in this particular underserved community.
Thanks so much, Stephanie. Chicago is near and dear to my heart. I went to school there, but our project has been principally focused in kind of the East Coast. But I would mention, in our engagement with health departments, I should say, state and local health departments has been really key, really, really key. I think, to some extent, the first step has been making sure that health departments and community-based organizations that have long been working within communities, helping them to navigate problems, solve problems, access resources, kind of strengthening those relationships first, and then looking for ways to also bring in other community leaders who aren't necessarily kind of community-based organizations, but who are trusted within the community, trusted messengers, into dialogue with each other. So part of that's kind of what we're doing with this language access program that we have. It's a cohort model where local health departments learn together, build language access plans together, engage with communities together, and kind of support each other as well in that process. I think, one of the barriers that we faced kind of initially in approaching this, collaborations with health departments with some of our local partners, depending on the region, in particular, I would say in maybe some of the southern states, we heard things like, we don't work with the health department reports people to ICE. And so that, that's really problematic, just kind of the disconnect between, just understanding the public interest, in the context of a pandemic where this is a really critical population that's kind of, again, at that nexus of spread that's being disproportionately impacted. But there's, this huge, not just gap, but enormous amount of distrust for historic reasons. Building that back takes a while. With other health departments, we've been encouraged to see folks interested, but just not knowing where to start, and that there's lots of tools available to create, language access is really, really fundamental to be able to actually communicate and engage meaningfully with folks in a way that's also culturally appropriate. So I think that's kind of a really great way to get started. But again, kind of community engagement through organizations that have been working for so long, who already have those existing relationships. That does require potentially some education. A lot of us were not public health experts at all. And I would say continue not to be, but are experts on kind of that trust building and helping to folks solve problems that can be useful for the future. And doing it now, not waiting till there's an emergency when people's time is stretched. That's something that there are resources that have been helpful. We could keep them going if they're to be used for these other purposes.
Thank you. I think if we could build those relationships and then collect data such that we could monitor what's happening at work sites, kind of like Dr. Carricker was referring to, that we can play that role as well. So thank you.
Great. Thanks so much. We're running up against time, but I think we'll get these last two in. So Mr. Craig, good to see you.
Thanks, Helen, and sorry I dropped off there. I do want to reiterate Ramadan sentiments of everyone that this is, I think, one of the best panels we've had actually on PACCARB, and I've been here from the start. So, I think that is very telling and testament to all the quality of the speakers, and I want to thank you all personally for not only your words today, but also your dedication to these issues and health equity. And in fact, working at CDC, I know this is an area where we are trying to do a lot more. CDC Director Walensky is committed to trying to address and apply public health activity engagement related to health equity. And to that point, I'll just flag for you that we actually do have a publication coming out next week. Give everybody a preview of coming attractions on health equity issues related to specifically infections, including antibiotic-resistant infections in those with dialysis. So that's another area, of course, where there's tremendous inequities for a variety of structural issues, a variety of other issues, and we're trying to put out some data to talk about some of those areas. But my question really is actually, more specifically and targeting and really adding to what Stephanie just noted. What are the if you were to give a singular recommendation to CDC and public health of what we could do related to health equity in your area that you think we could make a positive contribution, a positive influence, a positive improvement, what would that be?
I'll start. I think for us, having the data publicly reported, I may get in trouble for saying that, but I really feel like people respond to whatever metrics are measured and reported. And if they are measured, reported, and then linked to reimbursement, then you've got it. So I think it's really easy for us to check a box, but we have to put some teeth around that so that large health systems know this is how you're performing from a health equity standpoint. This is public knowledge and your reimbursement will be tied to it. Then it'll get a lot of attention and focus.
And specifically health equity measures.
Absolutely.
Okay.
Yes. And disparities. Because we know they're there, but we don't like to look at them. Yeah. And I think if they're in the lens of the public eye and reimbursement is tied to them, then it makes us not only have to acknowledge, but it makes us have to address it.
Thank you.
Yeah, great. All right, 2 minutes. Dr. Sheftel, over to you.
Hi, this is maybe more of a comment, but it's directed toward Julia Coburn's discussion and marvelous talk. I guess at the health, I work at Minnesota Department of Health, and my job during COVID, being a veterinarian, was critical infrastructure, including our meatpacking plants, animal ag facilities, and other things like manufacturing and construction. But So I was on the scene with the meatpacking plants on site before COVID hit, trying to help them get ready. And I just do want to say that if you want to have change happen, there has to be more of a two-way conversation. Because public health, we hear from the immigrant and migrant workers who are injured or have complaints. And one of the things I did at the health department was call management and say, what's going on? This is what we're hearing. And oftentimes that would get fixed. For example, we got a complaint that some of the workers had to wear the same mask all day long, and it got soaking wet and it was horrible. And so I called management and they said, oh my gosh, we've trained our regular employees, but that could be a training deficiency in our contract workers that come in, because we have barrels of masks all over the place for anybody who wants a fresh mask at any time. And so you're right about the line speeds and how dirty and difficult the work is. But the people who own those places want to keep their workers. They can't have people leave. What happened during the pandemic is, they were ordered to stay open and running when every other business was ordered to close. And I was on site with one place where they got 10,000 masks in from China because there were no masks available in the U.S. for meat production. And so I've never seen people so happy to get masks in the door. And and I had communication through the pandemic with these folks, and one of the meatpacking plants called me and said, we have an 80% vaccination rate in our employees, because they would have barbecues and vaccination clinics at the same time. And in that county, being a rural county in Minnesota, less than 40% of the community around them was vaccinated. So it can't just be viewed from one, point of view and think you understand the whole picture. Granted, the industry, can be helped, but we do have to communicate with them in order to help the situation in full. I wonder if you have any comments about that.
Oh, I do. I get, I'd say, asked all the time, what are you doing to work with industry, directly with PACs? We work with unions, for example, who have direct negotiation and have been very instrumental as well in kind of alignment among best practices. Where we come in is because a lot of the resources and attention have, from the federal response, have been directed at industry. There's a lot of communication there, health departments talking to management. Communication is easier. Management often speaks their language. But where we've come in is to try and fill the gaps where those efforts have not been enough, haven't been sufficient. And it's true. We don't, as kind of a legal services organization, don't tend to hear workers calling us just to tell us how great their experience has been. We tend to hear really the bad stories, the problematic stories, where there are emergencies, and try to figure out how we can help there. So there is certainly a bias, I think. But I do, given how left behind this population has been structurally, the economic and social disparities that they face, paying proportionately more attention to them, I think is certainly what's needed. And maybe to answer Michael Craig's question earlier as well, I think if we had one thing that we would ask for right now is just to continue for the CDC to continue funding the cooperative agreements that they've set up to partner with community-based organizations and networks like ours to try and reach populations. We've made so much headway, built lots of trust and great relationships, and have a lot more work we can do. And what's great about these cooperative agreements is we're not just talking about, funding to, and then goodbye. It's, a two-way street where, we're able to bring community feedback to CDC, bring CDC guidance to communities in ways that are culturally adapted, and try and, problem solve together in kind of a 360-degree manner, which has been really, really great. We've been able to get support on, understanding, public health technologies and vocabulary in a way that we haven't had, and that's been extremely instrumental to make sure that as messengers we are also communicating trusted and official guidance, as opposed to being trapped in misinformation webs that are disguised as something else. So I would continue to invest in that, while also continuing to invest in the approaches that work directly with companies and employers. Absolutely needed. That's kind of where oversight needs to be, and regulation as well, and continue to support that, but also just don't want to leave migrant communities behind.
Great. Thank you so much. Thanks to all of our speakers for incredible presentations, and to all the council for great discussion and very thought-provoking. I'll commend you all to Tim Jenks's comment in the chat that calls on us, the council, to act. And I'm going to leave. I can't say it any better, so I'm going to leave it to everybody to read it. And thank you all, and turn it back to Jomana.
Thank you, Dr. Boucher, and thank you all for joining us today and reminding us of the populations that we have to keep in mind as we go through these meetings and these sessions and the reports that we draft as recommendations to the Secretary. It's a consistent reminder, and we appreciate you bringing all of this to our attention. The conversation continues. We're still going to discuss health disparities and addressing equity, especially within the context of pandemic preparedness. So it's not much time. Grab a quick bite, and we'll see you back here at 12:40 for a prompt 12:45 start. Thank you all.
Produced by the U.S. Department of Health and Human Services.